I think we're ready to start, everyone, so let's begin. My name is Brian O'Connor from the European Connected Health Alliance. Welcome, everyone, to the second webinar of the Digital Health Society. And I just want to thank you all for joining us, and we have a good lineup today, a tight timetable as always, which Julian will handle. But my first duty is to welcome Anne Avikso from the Ministry of Social Affairs in Estonia, who will give us the Estonian EU Presidency update, and then we'll take it on from there into the task forces. Over to you, Anne.
Julian. Thank you, Brian. Thank you, Julian. I am really happy. This is the first slide you saw in July, and that was when we discussed first time that we see Estonian presidency really as a platform for moving forward the issues and discussions, not only amongst the usual government decision makers and in discussions with the Commission, but also broader stakeholder involvement, and the ECH Alliance has been a good help in that. So I will go very briefly through what is the status and what we do expect from all this. So on the next slide, there is a reminder of why we think free movement of data in healthcare is relevant for health systems. Increased access and safety, very clear mandate to act upon it. Another thing is sustainability of health systems, again something which is very important to each individual member state, but also to the community across Europe and together. And last and not least, a digital single market is something that is expected to boost economic growth in Europe, and healthcare and data-driven research and development again needs good and strong momentum also on behalf of health system. Well, the very short mantra that we are using to promote the agenda is that we know healthcare data is very sensitive, and we know that security is very important, and therefore we think that security while using health data doesn't mean that it should be secured from being used, but really to be put in use, but done so securely. So next, again, if you might recognize a little bit the formation of task forces on these three very important components and the combination of that. So there is technology and standards, there is legal framework, but there is also processes around that, how you implement the technology and the law, which can be titled as data governance. So we are acting and expecting action on all those frontiers. So next are the two focus areas. So right of citizens to control the data, something that in next May will be mandated to all countries, member states of the European Union, based on the General Data Protection Regulation. And then, as part of this, is also how to get growth and more targeted health systems by using secondary purposes data for research and innovation. Next is, again, if you press now, well, again, kind of summary what we have proposed for the, yes, thank you, for the discussion. We know that member states have their own ways how to implement GDPR, and this is something which has been agreed. Now, we also think that by coordination, this could be done in a more efficient way, and Digital Health Society and these task forces are expected to provide one of the vehicles how to get this implementation in a more coordinated way. Next is now really the context, and there is one box that should appear also in the bottom if you press one more. Right. So we are expecting all of you to Tallinn in just 2 weeks, where both the task forces but also all other important activities will be reporting, and companies will show what is the existing experience of the health in the digital society and what digital society can offer to health. Now, digital health society itself, we hope to hear what is the process with the stakeholder declaration, a very important part of the presidency, and then the task forces hopefully will deliver something that then stakeholder organizations, but also government organizations can, so to say, sign and commit themselves into real actions. And on the background and the quintessence, I believe in December we are expecting health ministers for all EU member states to sign council conclusions, which would then give strong mandate for all the suggested actions coming from these task forces. But also we know that the Commission has initiated a open consultation and is preparing their communication. This is the context that we expect to have tangible results by the end of December. And on the next and my last slide, you will see specifically where we see the digital health society. We all have been in different rooms discussing the same issues, and the idea is that this is a complex area, and in order to move forward fast, I think the small initiatives have all proven to be right, and all of them also, in the end of their final reports, usually demand for more coordinated action. So digital health society hopefully will help to bring that, starting from the declaration, then the task forces that you hear about, 4, which have been active and consolidated, and as a sign of potential liveliness of this initiative, we also hear about one, we call it action group amongst ourselves, which if there is equal support to what we saw for the first 4 task forces, could also transform into task force. But more in detail by those people who actually are driving these matters. And again, I hope a little bit reflection from this webinar today on if we all see that digital health society is delivering value to the extent that perhaps we can do something already over the next 2-3 months, but most probably big part of the work remains to be still implemented further on. So to keep the momentum, if there is a feeling that digital health society could and should continue, that would also give us some indication to prepare for what could be the future for digital health society. But today really is something to a little bit hear back and get the feeling. But more focus is on the results that task forces have to report today. And with that, again, thank you very much, everyone who has contributed. And with this, I give it back over to you, Julian.
Thank you very much, Ian. Thank you for this very good introduction, telling us about the context. As Ian underlined, we in the CH Alliance, with the Ministry of Social Affairs in Estonia, and several thousands of people, I would say, this summer we have tried to work to make tangible the digital health society and make it today, make it clear for everybody in order to launch and generate some concrete actions, concrete commitments, as I presented just before, and concrete projects. So just to give you some rules of the game for this webinar as well before we start the Digital Health Society Task Force's presentations. No, just before Matt, please. You're all by default mute, so you won't be able to speak during this webinar, but you will be able on the right side of your screen to enter in the question box. You will see a question box on the right side of your screen on the control panel, and you can type some questions, because we will have the opportunity to answer some questions for each task force. Each leader of task force will present first, and then we will take a few questions. I will have the role to select these questions, but feel free to type your questions during the presentation or just after, and I will try to take the main ones, or the main concern you can have, or main interrogation you can have on the different task forces. So this is the rule, and we will have as well a series of questions at the end, if at the end of the session, on a global approach, if we have time. So just to introduce quickly before the presentation of task forces, just to recap that the Digital Health Society, the name we have decided to brand this group of activities. So under this name, under this title, Digital Health Society, we have three elements. One is the declaration, the second one are the task forces, main topic of the day, and third, the event. So next, Matt. So to give you an update on the declaration, we launched, as you know, a consultation starting in July at the beginning of the presidency, and ending on the 31st of August. So it was a summer consultation. Despite this summer time, we had a lot of input and a lot of suggestion and proposition for this document. I remind you that DHS Declaration is a kind of manifesto of a document where we have listed some challenges we have still in Europe about the implementation and the deployment at large scale of the digital health in our healthcare systems, and so more than 125 people and organizations replied. These contributors are policymakers, are representing patients, are representing companies, startups, universities, hospitals. We have a lot of insurers as well participating, so the public and private sectors are represented, so it's a very rich contribution we received, and we expect to release a new version on the 10th of October, so next week, trying to integrate at the moment the different contribution in one single document, and the objective is to be able to have a co-signature of these contributors and all interest stakeholders, because if you didn't send a contribution, you still can endorse the text that we will release if you agree with it. So I invite you to have a look, and we will be informed actually about the publication of this new version of the declaration, the DHS Declaration, and we will invite you when it's published to co-sign and co-endorse this document. It's an interesting initiative because usually the presidencies are mainly institutional activities between ministries, and here we have a really mix between institutions, policymakers, but as well all the civil society, companies, university and research, hospitals, manager and professionals, etc. So it's a very broad consultation, broad document, so the idea is to have a kind of consensus on what are the challenge we have ahead. Next slide, Matt, please. So we will go in the heart of this webinar. So the presentation of the different task forces. After that, I will speak about the event that we have this month in Tallinn. But first, talking about the DHS task forces, you see here on this slide the different topic we have selected for this. I was saying, and I think some of the leaders will speak about, we try to have task forces and experts in these task forces focusing on really key issues or challenges we have in the deployment of digital health at the moment. So the first one is around interoperability, the second one around data governance, the third one about legal framework, and the fourth one about digital transformation. So you see here the leaders who led these groups of experts, around 10 to 12 experts working this summer, and we have to thank them for the time they allocate to us to work on these different topics. It has been intensive and it was sometimes during holidays, so thank you very much, the leaders and the participants of the task forces. And the idea today is to present the conclusion of these discussions happening this summer. We have decided for practical reason to close these task forces during the summer to end up with these conclusions and this presentation today. But now the task forces are really open to any active forces wanted to join the group. The idea is to launch now, as Ian said, tangible actions, commitment, and projects to progress on these topics. We think that these 4 topics are really key if we want to deploy digital health in Europe. So we expect after this presentation and after the communication we will do around these task forces to receive some suggestions of projects, and Digital Health Society trying to act as a kind of facilitator for the development of this project regarding the partnership, regarding the funding, etc. But we will talk about that a bit later. So just going deep in the task forces, so we go directly to the first task force 1, called Convergence Roadmap on Interoperability Standards and Digital Health Protocol. These task forces were led by Erik Gerritsen, Secretary General of the Ministry of Health in Netherlands, and the presentation today is from one of the closest collaborators of Erik, Erko Koemans, with advisor of the National Health Information Council. Working for the Ministry of Health in Netherlands. So Erko, I will give you the floor and you will present us what you propose for this topic on interoperability. Erko?
Okay, thank you, Julian, and thank you, Mr. Avikso, and the Estonian Presidency and the ECH Alliance as well for organizing the Digital Health Society initiative. Like Julian said, my name is Herk. I work for the Dutch Ministry of Health, Welfare and Sports, and we are leading the task force on standards and interoperability. Erik Gerritsen would like to excuse himself because he wasn't able to do this webinar himself, but he will be there at the eHealth Tallinn event in 2 weeks' time to do his presentation on this task force. And we want to take this opportunity to share with you our ideas and our intent with this task force, what we want to achieve and how everyone can participate. Next slide, please. First of all, the DHS Declaration. Julian already talked about it, and we are very happy to join this declaration as soon as it was presented. That was a special session in Malta. And Mr. Gerritsen said, let's do this, let's focus more on action and less on documents and wording, because we completely agree with the intent here that we already have. So let's make this real. And that is why we are also leading this task force. Next slide, please. Because we see this, the DHS representing a dream. It's a dream where health data flows safely, securely, and freely, where patients use their data to manage their own health and are equal partners in managing their own healthcare, where healthcare professionals have relevant data at the right place at the right moment, where research into new treatment diseases is vastly improved because of safe and secure access to high-quality data and highly sophisticated information infrastructures, where healthcare systems are able to evolve with society and the state of the art, where public values such as trust, privacy, and safety are protected by laws. Next slide, please. And we believe in that dream. And that is why the Netherlands refers to this as our flourishing ecosystem. And an ecosystem needs 2 things. One is the good climate, and one is the fertile ground. And you see in the climate part, the plant, the leaves of the plant. That's what we want to achieve. Those are our goals. Fitting funding models, integrated care solutions, skilled professionals and citizens, laws that protect the public values. But for that, we need to invest in the fertile ground. And those are standards in interoperability, change management, data governance, legal framework. They seem like the tough, boring things, but they are not. And this is what the DHS task forces focus on primarily. Next slide, please. And this is what we want to do. We want to go from a coalition of the willing to the coalition of the doing. And it's a very simple notion, but it brings together people, institutions, regions, governments, systems, nations even, that are actively working on removing the barriers and realizing this dream. And this is what we took as our primary goal, to show what we are already doing. So let's share the building blocks that we have already created for this foundation for our own fertile ground. And this is how we started this task force. Next slide, please. So this task force is called the Convergence Roadmap on Interoperability Standards. And interoperability is a recurring theme with many, many facets. And since time is a scarce commodity, we wanted to start with what everyone is already doing and has done and has already in place in removing the barriers for interoperability. Next slide, please. And then we wanted to link the standards that we are already using to the desired outcome, because using standards isn't the goal in itself. It's a continuous discussion here in the Netherlands as well. As soon as we start discussing standards, they immediately start discussing what do we need the standards for, and is it a means to an end, or is it the other way around? Compliance and adherence to standards is always a big issue in most European countries, as is implementing them. It takes time and knowledge and money and attention that is often meant for healthcare itself. So when we publish a list of standards, we want to ensure that these are actually adding value to the quality of healthcare delivery outcomes. They need to solve interoperability barriers that we now have. And we found a tried and tested framework for this in the Interoperability Standards Advisory from the United States Department of Health and Human Services, Office of the National Coordinator for Health IT. That's a very long title. To practice how this would work for our own standards, we took one of the areas where interoperability barriers are actually costing lives in the Netherlands, which is medication safety. Next slide, please. Next slide. Thank you. Oh, sorry, one back. So we created a list of interoperability needs in medication safety, and we listed the standards that are necessary to break those interoperability barriers for them. And basically that there are many types of standards that you can list or apply. So we needed another framework to structure the standards that that are mandatory for medication safety. And standards can be applicable on several levels. So we used the European Interoperability Framework for this, and it boils down to these interoperability needs, which most clear barriers and need and interoperability needs at the information level. So you see medication safety policies are at the organization policy level. Transfer of medication data within the chain is in the healthcare process level. And you see lots of standards listed in the information level with both the semantic and the syntax structure and the language. With electronic prescription, identifying and naming the pharmaceuticals medication overview, medication agreement, provision request, etc. And then for the application layer, there's the exchange of medication prescription and overviews, like e-prescription. And for the infrastructure, there's the transport of medication data. That is what we sent to everybody. Next slide, please. And this is what it's a Dutch image. So excuse me for the Dutch language in there, but this is what it could look like. If we could create a map of standards that are being used for different interoperability needs, in this case, the interoperability between the person prescribing the medication, which is often the doctor, the GP, or the medical specialist, with dispensing the medication, which is often the pharmacy, and administering the medication, which is often the patient itself, or a home nurse or someone else. Then we need to solve the interoperability needs between them, because everybody within their own area of expertise is able to use the standards themselves, but we want the chain to be interoperable. So here you see the standards all listed in the different kinds of levels and where we use them. Next slide, please. So this is what we sent everybody for the first consultation, and we asked 2 questions, and those are: what do you think of this approach and the framework we propose? And the second one is that we need more data, basically. We need more standards. We need to create a list of which standards are used in what areas, and so we can create a full list. So please add your own use cases for interoperability needs and the corresponding standards that are used there. And with the structure that we've provided, which is still open to discussion, we try to create a map of Europe. Next slide, please. Where, thank you. We create a map of Europe where we can see which standards are used where. Next slide, please. So this is what we hope to achieve. What if we plotted all the interoperability standards that we now use in our own healthcare systems on a map of Europe? And this will tell us at least 3 things, and there's probably a lot more spin-off that can be done with this, but this is what we aim to do with this task force. It will show us with whom we can already communicate, which is very basic, but because we already have the use cases there, and then we can see in which use cases we can communicate with other regions, systems, countries, whatever level is appropriate for the use of these standards. And we can see where to look for best practices in standards adoption and use, because, like I said, the Netherlands doesn't really have a complete list of standards yet. This was just one use case for medication safety, and there's other use cases as well. And we can learn a lot from how other regions or systems implemented their own standards and are actually using it. So it's not about the standards themselves, it's about the use of them. And lastly, we can see what the European market is for products and utilize these standards. So the Netherlands is too small a country to define the standards on its own. If we truly want to work on a digital single market for Europe, for healthcare, then sharing what standards we are already using is a logical and necessary first step. That is what we try to do with this task force. So next slide, please. So in time, we invite everybody to join this task force with their own use cases and the standards that everybody is using. And we hope to create a map of standards. We will add our own other use cases to the list as well. So for us, it's ongoing process, ongoing work as well. So in Tallinn, we will present a bigger list, and if anyone is able to send them their lists of standards, then we will add them to the map. Thank you. That was my presentation.
Thank you very much, Ko. Thank you for this very clear presentation. I remind you that you can type questions in the question box at the right side of your screen. So waiting for the first question, Ko, I wanted to ask you how you think you will organize this consultation, and who are your target contributors. So from who you expect the information coming on these use cases and the associated standards you can have, and perhaps some proof of concept and proof of interest. And will you, because you work on this specific template to map the use cases, will you provide such template? How do you see the work in the next month?
Those are 3 questions, I think. The first one is, yeah. The first one is who do we want to participate, basically. In the first round, we asked some of our fellow governments who we know are working on registers or already have working registers and lists of mandatory standards within their healthcare system. And some enforced by law and others not so much, but by consent or by purchasing power. So that was our first group of organizations that we asked, and we found that while many thought that this was a very interesting initiative with the vacation and lots of work and scarce time, it was difficult to get the time to participate in this task force. So that means that we do not have a lot of input yet from other countries. And that is why we are very much for broadening the scope of the participants. So basically anyone who has a standard in use and has a use case for that standard or that set of standards is free to bring us the input. The condition is that it needs to be used in practice, because otherwise it's not an active standard. And we provide, of course, the template, which isn't, like I said, it isn't ours. The United States created this and had a very extensive consultation on the model, and it's still ongoing. So they keep refining it. But of course, the template for Europe doesn't have to be the template. If you have alternatives, we love to hear it and make that part of the discussion as well. So we basically have 3 deliverables. One is the list of standards and use cases which are active within Europe. The other one is the template for registering these standards. And the third one is, I think, a map of Europe, which could be more like an application than just a static map, where you can see which standards are used in which parts of Europe.
Thank you. Other question was, so you mentioned several times the ISA, the American tool. Do you know which kind of positive outcomes or benefits it has generated in US? What because it's the ONC is not has not the power to oblige and enforce the states in US to adopt these standards. So it's a kind of they look for consensus, and they have different working groups on different standards, etc. What are the benefits that have been observed in US for this ISA tool?
Well, basically, the ONC needs to answer this question fully, but I really recommend going to their website at healthit.gov to check out more information. But what inspired us is that it's basically a feature that they cannot federally require use of standards, but create the standards advisory as a means to get everybody to know which standards are best practice in which situations. And what I love about it is that they start with interoperability needs. So they didn't start with the solution and then finding the problem to match it. They started with the problems and then list the best practice solutions that are available for this. And they also have the status of every standard in there. Some are federally required, some are required for certification for the Meaningful Use Program or other federal programs. But basically they allow this for insurers, for instance, when they when they buy in purchase healthcare from healthcare providers and healthcare systems, they can set demands for and refer to this list of standards and say, well, if you work with these standards, you're compliant in our healthcare system. So basically, the fact that it's not mandatory is a feature and it's not a bug.
Thank you. Okay, thank you very much, Arco. We have to switch to another task force, of course, in the next. So this webinar first is recorded, so will be available on our webpage, and we'll send you the communication afterwards. And we will indicate as well how you can participate to each task force, giving you a contact point and template, as it is the case for task force number 1 in the next days. So we will communicate on that. Thank you again, Arco, for this presentation. So now I will introduce Angela Brand. Angela is a professor at Maastricht University and has many responsibilities. So sorry, Angela, I won't mention all your roles. But Angela is involved in many initiatives around data and especially health data in Europe, with a large approach of what is health. But I'm sure Angela will explain to us what has been discussed within this task force number 2 on data governance. Angela?
Yeah, thank you very much. Thanks a lot first for putting the task forces in place and having the chance to develop ideas, and also thanks a lot to the task force members. Next slide, please. So where we are, what solutions, what initiatives are already in place, how is the landscape? We have already, I think, many technical solutions and tools which are in line to the implementation of data donor citizen controlled good governance models. This is, for example, Bitcoin and blockchain, or to make use more of artificial intelligence. Then the European Open Science Cloud idea, and also maybe that is something to discuss also lined up with Task Force 1, the integrating healthcare enterprise standard, which is internationally available. Then we have political commitment and tools. Just for example, in many approaches, in many strategies, the citizen-centered approach is no longer a question. Then we have policies like health in all policies, where health is an issue in many other fields of policies like trade, security, etc., and health in all politics. And then we have, for example, also like the cross-border healthcare directive, which is also a framework we can already use. Next slide, please. Then we have European frameworks and principles in place. And for example, the 4 common values and principles in EU healthcare systems, which are solidarity, universality, access to good quality care, equity, which had been adopted by the Council in 2007 already under the Together for Health strategy. And then we have very general, not only related to health, but to all fields on European level, the three principles of solidarity, subsidiarity, and proportionality. And I think the last one is especially also important for our discussion here. Then we have the digital single market strategy, where explicitly it's already said that there should be access to the own health data. And then under the Estonian presidency now there is a discussion about the fifth EU freedom. Could it be digitalization, gigabit society? And that would be a major, major step forward. Next slide, please. Next slide, please. What needs to be changed? What is missing? Before the slide, please. The current models for governing data for better health and healthcare are based on an outdated assumption of data protection and data security. This is like a mantra, and we should not continue, I think, that debate. This does not work for the future. We need to think about other models. And what is missing, we came to the conclusion, is a good governance model. Next slide, please. And what should be criteria of such a good governance model? What do we need? It should be a good governance model for citizen-owned and controlled data. It should allow for both, which had been discussed in the last days during the presidency. It should allow for both the free flow of non-personal data and also access and reuse of data for future known and unknown purposes. It should go beyond health data and IT solutions for health, so that we are not stuck in the sectors, but more horizontal, look about horizontal solutions. And also it is important to understand that data are a central part for health research, healthcare, and health improvement. We need data to improve, like Robert Medlin said, it's the blood, it's not only the oil. And it has to be in line, such a governance model, with the forthcoming EU Commission policy paper on the transformation of health and care in the digital single market, and also, for example, with the Cloud Council recommendations. Next, please. A solution. What could be a solution? What is the idea of the task force? We need a pan-European good governance model, putting the citizen in the driver's seat, and to make best use of the technological innovations which we have, and health data for individual benefit and the common good, so for both. And that we can see that there is one solution we could go forward, which are health data cooperative or even data cooperatives, where health is a crucial part, or maybe the most crucial part in it. And that would mean that the citizen is a creator, is a nature interpreter, the controller, the owner, and also the sharer of the data for primary and secondary use for all kinds of purposes, and in a trusted entity. That's a unique selling point here, and even beyond the healthcare sector. Next slide, please. The definition of a cooperative, and here I would like to use a definition from the International Cooperative Alliance, is that it is an autonomous association of persons united voluntarily to meet their common economic, social and cultural needs and aspirations through a jointly owned and democratically controlled enterprise. Next slide, please. Then what we see, that the idea of a health data cooperative is very much in line with the My Data movement. Just 4 weeks ago, we had a big conference in Tallinn and in Helsinki, and there is a My Data Declaration, which had been signed by many institutions and stakeholders. And this is, for me, the central picture of that movement, that on the one hand we have the data sources, many kind of data sources, and we have data using services, also all kind of services, whether public or private. And in the middle there could be an operator. And in our case, the idea would be that these operator could be the data cooperative, where the persons and the citizens are members of this cooperative. More information regarding that declaration you can find under the link which we provide here. Next slide, please. Why are we thinking about a cooperative model? Why is that so unique? It's truly bottom-up solution, so citizens are in the driver's seat. It's truly democratic solution for Europe and beyond, also globally. It includes all various types of data donors. That is also in the topic of our task force, whether these are citizens, patients, companies, administration, etc. One person in the cooperative has one vote. Then the data can be stored in an intelligent cloud. Cooperatives are already established, not only in Europe, but globally. In Europe, all legal problems are solved, have been solved. We have even cooperatives in the health sector, on health promotion, for example. Then the citizen, the human being, is an interface, what I described before, the supercomputer, somehow the holistic data integrator. Then there is a chance, the possibility of horizontal use of data, of health data, and it's very much in line with the health in all policies approach again. Then it's based on data commons, knowledge commons, commons agreements. It's balancing personal benefit and common good, and that's the only model we can think about where we really can assure such a balance. Then there are many business models possible, where there is benefit and incentives for the provider and the user, so on both sides. So even the cooperative as such can be a business model. It's useful for primary and secondary use of data, and there is even a statute for a European cooperative society. Next slide, please. So the question is now, what could be the next steps? What can we concretely do? What funding and pilots or proofs of concepts could we think about? With funding, one could think about, which will also be, I think it's a Tallinn event presented, the smart cities, the role of smart cities, whether a smart city could say, well, we would organize ourselves in a form of such a cooperative. Then the European Investment Bank, or the EU member states or regions themselves. Then, of course, European level, DG Connect, DG Santé, for example, and also concrete funding mechanisms like the IMI, the Innovative Medicine Initiative. But there are many more possibilities, and I think this is also the goal of the webinar, to think about more funding and pilots. Next slide, please. So pilots could be very general, proof of concepts, but also very concrete. It could be to develop a toolbox for health data cooperatives. What are minimal requirements we should have? Then it could be business to business money initiatives like the virtual knowledge banks. One could think of cross-border pilots, the implementation of a cooperative cross borders, and also here thinking about structural funds, for example, as funding mechanism. Then, depending on the various stakeholders, whether they're public, private, etc., and the local needs, one can think about a lot of initiatives. So to start very small, and it could be scaled up. It could be questions around health, which are, for example, neighborhood management, quartiers management, hospital management, or very disease-specific patient groups, self-help groups, for example, around a rare disease, social networks, and then again also the smart city, and what is also the beauty of that concept of a pilots, that one could try how it complies with existing other initiatives. For example, just recently the collaboration for oncology data in Europe was launched, or Takeda's from the pharmaceutical sector, etc., etc. So there are many, many possibilities. And last slide, please. I would like, next slide, please. Next slide, please. Yeah, I would like again to thank the members of our task force, Robert Medlin, Matthias Reumann, Richard Bergström, Antti Poikala, Ricardo Baptista Leite, Nikos Evangelatos, Helmut Brandt, Lada Lanes, and Peter Kapitein. Sorry, there's one typo. I see Antti Poikala, who organized the My Data conference. He's at Aalto University in Finland. Yeah, thanks again. And now we are very open and interested in getting feedback.
Thank you very much, Angela. Thank you. And sorry, Antti, I know you're online. You're from Aalto University, so it was our mistake. So we have a number of questions already, Angela. So first question, if the individuals are the creators and interpreters of data, who is the validator to ensure high quality of data is maintained? How will this achieve in your model?
Yeah, for example, it would be that this is how one would define quality of data could be part of the toolbox. That's the first thing. The other one is when, for example, would be the task of the cooperative as such. So not the individual could control the data, but the cooperative on behalf of the individuals. And again, the individuals can be citizens in different roles, as patients, as citizens, as also from a company, from a public service, etc.
Okay, thank you. And a related question, perhaps, how can we guarantee that the data stays available for research when the citizen wants it and maintain the data?
That is a very important point. Yeah, that it stays for research and it stays in the cooperative, so the sustainable and use of the data. This is a central point. That's why we also said that the data have to be provided for health research. One can think that there are, for example, also decentralized cooperatives, and but that they talk to each other, and for example that they create an in between a platform where for specific purposes. So here the research would be an ongoing question. It's like a little bit I would call it the Ebon for health data, the Ebon from account. Something like this.
Okay. Well, similar question, but on the private side or commercial side, can the cooperative establish a commercial enterprise to sell data for the financial benefit of its members with their consent?
Yes,
obviously.
yes, definitely. And we had discussed that before also with industry. And that is, for example, just one example, if a pharmaceutical company or many companies together in the co-development of a drug, for example, they would ask the cooperative to provide data, and that would be possible, and they would have to pay for the data. What is very important that industry can participate is that the incentives going to the individuals would not be in a monetary way, so that citizens would not get money for that into their hands, but that the incentive would more in the way to say what from the money we earn in our cooperative, what different incentives could be there. For example, building a school, better a new hospital, or a premium. Yeah, exactly. Many ideas could be. But the essential part is that the citizen would not get money into their hands, so not the monetary benefit. I think that is very crucial in that model. And that is only then possible that industry can really participate and make use of the data.
Okay, thank you. Perhaps the last one. One of our attendees is commenting that the technical change is likely to be the easiest one with the solution you propose. What about the cultural change of European citizens?
That
Do you
is
think
what
citizens already do that?
Yes, I think there are. We see that in many areas, citizens even demand it. Like we have cooperatives, like I said, already organized, but specifically, for example, from the rare disease community, they've been always very open to that. Also that they say themselves that health data are not too sensitive. We overstretch, really. This is also like a mantra, and we are willing to share. So I think they, in principle, they are ready. So I think from the citizen and also the political will, there might be, of course, ways. And that's why it's important. The cooperative needs to tackle the cultural differences. So a cooperative in Spain might look very different from a one in Estonia, or even globally. We discussed it also, for example, in other continents in India, and I think there will be also a delegation at the Tallinn conference from India. It would be very different there than, for example, in Europe. So that is, I think, to be successful, these cultural differences need to be addressed in the way the cooperative is organized, and also what are maybe topics to start with, because we have to show the benefit to the citizens very clearly.
Thank you, and just to mention as well that as people can see on the slide, the complete title is about data governance controlled by citizens, but as well data donors. This concept of data donors is something we started to discuss, but we will continue to discuss within this task force about which kind of communication we have to launch again and across the society in Europe about sharing data and how to use this data. But obviously, the main question will be from the citizen how I can control that. So that's why we answer for the first question. But of course, in this task force, you have some passionate representatives and. Such as Peter Captain, for instance, you mentioned, and the idea is to work on this kind of communication. Thank you very much, Angela. We will continue with our third task force. Of course, like the previous one, we will give some information through email and on our website about how to engage with this task force. The idea is to build on this cooperative model, so every person interested to work on that will be invited to contribute, and we will put the detail how to contribute in our webpage. And thank you for your questions. Sorry if I'm not able to take all questions, but I try to do a selection for the topics happening more in your questions. So, but we will try to have as well a concrete answer to each questions, and we will work with different leaders to do that. So, third task force, thank you, Angela. Third task force is led by Bledin Rees. Bledin is a digital health expert and a lawyer. He's a lawyer at Osborne Clarke, as you can see on the slide. And he was leading and is leading the task force number 3 about the legal framework facilitating the free flow and the second use of health data. So, Bledin, I hand over to you.
Thank you very much, Julian, and thank you for to the Estonian Presidency and to the ECH Alliance for giving us the opportunity to work on Task Force 3. Next slide, please. So just quickly by way of introduction, the main feature of this task force is the fact that the European Union has no power to harmonise national health laws, and the rest of that slide really is dealing with why data is so important to healthcare systems. And perhaps in passing, just to emphasise that we took a view that it was both health and social care data that we were looking at, not just healthcare. Next slide, please. So the substantive proposal that we make is that the framework has to be outside of the formal European Union, who have no power to harmonise healthcare. So the concept is to create a European Health and Care Data Convention. This convention has some analogy with the European Patent Convention, for those of you who are more interested in technical legal issues. And it's founded on, we're suggesting, 9 principles. And then the key thing to understand is that each region and country on a voluntary basis would sign up to the proposed convention and its principles. And the last recommendation there on that slide is just about whether the convention is itself binding or non-binding. Next slide, please. So the objective was to create some common legal rights and obligations for citizens and patients to underpin the free flow of health and care data and its secondary use. And in this context, we started to get into what we believe are going to be the most important use cases for this data, and that picks up some of the things that Angela was starting to speak about. So next slide, please. So principle number 1 is simply to create an electronic health and care record, and clearly in countries where that are state funded, this to a lesser or greater extent is already happening. And then certain key features that we were suggesting that were important, so the ability to record consents or the removal of consent, permissions for family to share information, particularly important for elderly people or people with perhaps limited mental capacity. And then finally, the idea of trying to come up with a more informed definition of what a health record would be for the purposes of this legal framework. Next slide, please. So the second principle, which the lawyers on the task force thought was really important to emphasize, is that all transfer of health data, whether that's for direct care or for second use, had to be lawful and specifically comply with all EU and national laws, and in the context of EU, particularly GDPR. 2, the citizens should have the right to privacy and confidentiality, and for healthcare systems to keep all information safe and secure, something that's probably been picked up a number of times already. We're not ignoring the fact that many healthcare professionals have ethical obligations which they also need to abide. And then just finally, that consent needs to be freely given and informed. And there were a number of views around whether informed needs to be clarified and have the same meaning across borders, also whether things like implied consent and explicit consent would benefit from the same definitions. So next slide, please. So the third principle was access for citizens and patients. So very simply put, citizens and patients should be able to access their health record free of charge. So a relatively simple concept. Next slide, please. The next is about the control of the record and who is able to access the record. And after some debate, we came to the conclusion that it ought to be for citizens and patients to control access to their record by anyone, with an ability in law for healthcare professionals to access that record in an emergency to be able to treat a patient. Next slide, please. So principle 5 we thought was really important. This is the idea that there needs to be communication and transparency in the use of data, so that the benefits of health data need to be explained both for individuals and for society as a whole in order to facilitate greater use of that data. And clearly, those who use the data, whether that's public health organizations, researchers, or providers, also need to explain what they do when they use that data. There's a clear need, we believe, for ongoing education and training. And finally, there's a need to improve this communication in order to obtain, we believe, lawful consents. So next slide, please. in relation to research, we thought that all identifiable health and care data requires explicit consent, but therefore anonymized data does not require any form of consent. And an interesting topic that we came up with, which Angela also touched on, was the question about whether, and we framed it as whether any individuals should have the ability to sell their data or access to their record if they wished. So principle 7, please, next slide. In looking at the research uses, we believe that there's some straightforward principles that you don't use personal confidential information unless it's absolutely necessary. You then use the minimum amount of necessary personal information for the research that's being undertaken. And that all identifiable data, just reinforcing the point, requires consent. And again, we thought that communication was going to be really important in order for people to understand the benefits of their giving consent. Next slide, please. Principle 8, the duty to share health and care data. The value in the record is only realized if the record is used, and therefore maximizing the use of the record is very important. Similarly, allowing people to access that record, whether they're care workers or hospital workers or primary care workers in different settings, is fundamental to the value of that data being realized and for patient safety. So the duty to share, we believed, was just as important as the duty to protect patient and citizen confidentiality. In this context, we were recommending that there needs to be guidelines around how data would be shared by health and care workers. Next slide, please. The final principle, 9, safe havens. We were recommending that accredited safe havens should be established for cross-border population-based research and statistical analysis and service improvement. This could be, for example, by national care organizations or research institutions, i.e. universities, or it could be the cooperatives that were just being explained. Safe havens could also be used for data donations by patients and citizens across Europe. And we believed that there was a need to explore the technical solutions for safe havens, whether that was the idea of federated databases, where databases never leave national boundaries, if you like. Next slide, please, then. In conclusion, in looking at the terms of reference, we've drawn heavily on a bill that was proposed in 2013 in the United Kingdom, but was never enacted as law, and what I think is a well-known set of principles called Caldecott, which we've slightly developed. Clearly, the principles need to be reviewed against the work of the other 3 task forces, and already listening this morning, I've a number of points that I've been noting to think about before the conference in Tallinn in a few weeks' time. The principles are intended to be high level and to form the basis of a coherent proposal for a convention. Thank you very much.
Thank you, Gladyn. Thank you very much for this very clear presentation. So we have a first question. I read it to you. How do you propose to address the needs of longitudinal studies which may require identifiable data following the patient over a long time and sometime in a cross-border mode?
Sorry, can you repeat that again? It broke up.
Sorry, how do you propose to address the needs for longitudinal studies which require some identifiable data on a long term for each patient and sometimes in a cross-border mode?
So I heard that it's longitudinal. So this is, I think, in part, this is the question of probably about dynamic consent and whether the consent can be specifically enough worded that it is able to extend over a longer period of time. So we believe that's possible, and I think that there may be some work, because we were suggesting that the definition of consent needs to be looked at. One aspect of that is the time-bound basis of that consent.
Thank you. We have another question. I think you mentioned it, but will a citizen have the opportunity to opt out of any use of his or her data for research, even when anonymized?
When data is anonymized, we're proposing that no consent is required, because there is no personal data or identifiable information in relation to that person being transferred. In all other cases, consent is required, and therefore there is no problem.
Okay, thank you. You had let in your task force some authorities, public authorities, which have already set up some processes in order to for the second use of health data. Which kind of contact you expect now with this communication and this opening of this task force to other contributors? Which kind of profile of information you are seeking?
So I think that that's a good question. I think that when we're at Tallinn, we are looking for still a broad engagement with, I think, researchers to understand exactly what their concerns are. I mean, so far, I think it's safe to say that many researchers, we're hearing that they are perfectly able to get consent. Consent's not a problem. But if there are researchers that have contrary views, that would be very interesting to hear from. I think that it would be helpful to hear more from businesses about access to data, as well as some more technical European lawyers who may have some experience to bear. As I said, because we are basing it on a consent-based approach, the opt-in, opt-out does not become an issue, although one of the things to draw people to understand is the distinction between opt-in and opt-out in the context of data consents, and opt-in and opt-out arrangements in relation to pure health laws. So, for example, a number of countries have said that it is compulsory that if you die, your organs can be harvested, and you have the ability to opt out of that. That has nothing to do with GDPR. It has everything to do with national health laws, and that distinction is sometimes lost between people, where they think the word opt-out is applying just in a GDPR context or data context, and it's not.
Thank you. Perhaps the last question, is it correctly understood that the Convention is not a legal entity but a guiding framework? How the EU cannot stipulate national law? I think the answer is yes. Vladimir?
Yeah, yes, and the idea of the Convention is that it might create a legal entity that administers the Convention, and that, for example, might be the digital health system.
Okay, and there is an additional question to that. Was there any discussion, or can you imagine punitive actions for those who are not circumvent such conditions?
Punitive action for what? Sorry, for
people who, well, for people or member states who don't respect this kind of this convention.
That would be something that the convention itself would then provide for. So what were the remedies for individuals and organizations where those principles are breached? But in fact, it's for the individual countries to pass their own national laws implementing the principles. So it would be a breach of their national laws and what that legislation said about what the remedies were in those circumstances.
Okay, very clear. Thank you very much, Bladine, and thank you all for your questions. Again, I didn't have time to take all of these, but we will try to produce some answers for your questions after the webinar. Now we are going to the fourth task force, focused on digital transformation and change management in health and social care organization. This task force is led by Richard Corbridge, who is CIO of the Health Executive Service and CEO of the Health Ireland. Richard, over to you.
Thank you very much, and I'd like to thank all the members of the task force who helped pull all this together. If you flick to the next slide, that'd be great. So over the period of time, we had 22 views and sets of content. The aim and objective of what we're trying to do was pull together the best practice from across the different members of the task force to try and make sure that we had a single place where we gathered information around business change relating to digital in healthcare. When you look at the 22 different views across the different organizations that took part, you start to realize there are around 9 different frameworks that align to each other with different ways of collating the ways that business change can be implemented. And it was really important to us as a group that we pulled together all of that information and went through a research process to understand the different ways that can be created into a single task, into a single toolkit for beginning to ensure that the different methodologies and the ways that digital health is changed through the solutions that we implement and how we put those in place. So if you flick to the next slide. As you can see, we had a wide group of people involved in the different areas, ranging from researchers through to the big corporations that are helping deliver these solutions, through to startups and new organizations that are working to put this in place. We concentrated on as wide a group as possible and tried to ensure that it didn't really make any difference whether this was a small project or a large national project that was being put in place. The volume of content that was provided has been quite phenomenal, with, as I mentioned, 9 different frameworks now created and over 10 research programs and research papers pulled together off the back of how to make this work. Ultimately with a guiding factor trying to get to having a toolkit that could work across the whole piece. So you could flip to the next slide. So through a series of conference calls, we collected the different information. We ensured that working through ARCH, which is one of UCD, one of the University College Dublin's groups, we were able to collate that information and evaluate the different areas. The calls were then put through a one-to-one process with the members of ARCH talking to each of the different members of the task force to ensure that we thoroughly understood the different ways that each member state, each member organization had started to ensure business change could be put in place. The specifics of change management and how it related to change in digital health was really important to how we went forward, and meant that by the time we get to Tallinn in a few weeks' time, the product of what we will have will be a downloadable set of frameworks and toolkits that enable anybody to make the best of what's gone before, but also we've put in place a process that enables any new ways of working, any new solutions to be brought into that, so that we can start to ensure that we pull forward a full detailed list of all the different ways of ensuring business change is successful. Next slide, please. The key findings, though, were relatively simple at a high level, which is around the fact that the money, technology, and people need to actually make sure that digital implementation is key. What we did work through was that those 3 fundamentals have different components at a macro and micro level, and understand how they interrelated, and made sure that actually when the toolkit came together, it would actually enable both at a macro, a meso, and individual level different ways of actually ensuring that the business change can be measured that comes from digital healthcare, but also made sure that the implementation can be evaluated from a benefits point of view. The inclusion of a stakeholder engagement element to the toolkit has always also been part of where we've gone, learning from lessons from the NHS, from Ireland and various other countries around the Chief Clinical Information Officer process and how we make that work. The next slide, please. So the toolkit, once it's published and once it's readily available, once we get to Tallinn, will have all of those different areas and will allow us to take from the outer ring that implement, plan, evaluate and learn and step through into project management, and how it works in both directions. So a series of measures has been collected from across the different areas, and a series of different best practices has been put together to make sure that anybody using the toolkit can look at the different interdependencies and actually sort of choose which areas that they want to use across their own business change that they're trying to actually see implemented. The organisational readiness and a toolkit to actually assess that, both based on some of the maturity assessments from the UK at the moment and similar maturity assessments in Ireland and other countries, has enabled us to not just give ourselves a toolkit for business change, but put in place some best practice fundamentals for actually evaluating the starting point for each of the organisations that are taking part. Next slide, please. So the key findings have been broken into the different areas I mentioned earlier, as well as looking at the engagement, finances, the technology itself, risks and ethics, and readiness. So within the toolkit, each of these boxes are clickable effectively to allow you to get to, if you want to get to the individual technology piece, you'll be able to get to suggestions around usability, training, and access. And the sort of table in front of you there is self-explanatory. The way we've tried to focus our work is how do we actually create best practice to project manage business change through digital healthcare implementations, looking at the different ways that they come together. I think the risks and ethics element that's been included in here is particularly interesting, as the different jurisdictions that have been involved in creating the toolkit have very different ways of handling those situations. And that's why the sort of pick and choose element of the toolkit is so important. Next slide, please. So it's a very quick whistle-stop tour of the work that's being done in that space. I guess from our point of view, a large part of this is actually to take us to Tallinn so that when we present there and talk to the people that are interested in finding out more and make available the toolkit that will give us a real basis to start to create more engagement around this area. Thank you very much.
Thank you, Richard. Thank you very much. So you have the possibility to write question. First question for you, Richard. Will the toolkit be able to handle issues, especially from, for example, country like where deeply rooted among the residents is the sense? Oh, sorry, I will copy you the question because this one is a bit long. But basically, the question is, how will this challenge brought forth by a country like Germany be addressed? They have all the technology and infrastructure, but lack the courage to dive in. Okay. So the question is more about...
Yeah. If you flick back one slide, yeah. So the way that it's envisaged the toolkit will be useful in that space is that there are different elements to the different areas that can be picked and chosen from different countries. So when we started to pull together the toolkit, it was clear that no one set of suggestions had got everything right. So the idea is this pulls together a lot of learning from all the different 22 participants in the task force, which means that whilst it won't be the perfect answer for any one country, it does mean that you've got 22 different views to be able to pick and choose from and use work that's been done successfully before. And I think we feel that's how the toolkit will be useful, because it gathers the information that's been used previously and allows people to pick and choose the elements they want to apply to their own business change projects.
Thank you. One question about cross-border relationship in this task force. Do you think that peer-to-peer review or peer-to-peer travel mission in different countries are helpful when you are leading a change in your health system or your hospital you've yourself led and you are leading at the moment in Ireland a big change, digital transformation? Was it helpful to see other examples in other countries in Europe?
Absolutely, it's been fundamental to Ireland's ability to learn and fundamental to creating this toolkit is to look at the different ways that different countries have done this. The first question there, clearly different countries have a different starting point, but there is so much to be learned from different countries. So the cross-border work that Ireland has done, we have a land border with a different country and therefore need to understand how we pass that information. Things like identifying the patient's information and identifying who's accessed the patient information has been a big part of that business change to make sure we hook all that together and continue to build that in the same way.
And this kind of international information you have collected was a tool you were using in your discussion with in-house people and the team you were working with internally? Yeah. I mean, is it a trigger for change?
Yeah, it feels very much like a trigger for change and a trigger for us to start to share more information, which was certainly where this conversation, this task force came from in Malta originally, was how do we share more so that we're not all starting at ground zero every time we try to do something different.
Okay, thank you very much, Richard. So the time is flying, so we will continue. Thank you very much, Richard, and thank you very much, the member of the task forces, and all of you for leaders of these task forces. So you've understood the message. We will publish these slides and more information in the next days. For instance, the toolkit on TF4 will be available in a few days and will be presented in Tallinn for the work of task forces. So we look for your interest, your contribution, and now these task forces are completely open to any stakeholder willing to act. So again, I insist on that, but as Ian mentioned at the beginning of the webinar, we look for proposal of tangible actions and projects following the lines that were presented today by the 4 leaders, and we are open to any proposition of project across Europe on these topics. We will now have the presentation about a new action group which was created recently to prepare potentially a new task force, the DHS task force, and this presentation, so the name of this task force is Cross-Country European Health Data Cooperative Network, an important topic, taking on, I think, many of the aspects we discussed across the 4 previous task forces. And Marie Rande from Denmark, Head of Secretariat of the Ministry of Health in Denmark, will present us this action group and this proposition of new task force. Marie?
Thank you very much. Can you all hear me? I hope so.
Yeah.
Thank you for letting me participate today. As you said in the introduction, this is a proposal for a new action group, which means that what I'm going to present today is a little bit more immature than what we have seen earlier today. I hope you understand that. Also, please, next slide, please. Thank you. We hope that what we can achieve in the upcoming weeks is that we will outline a concept note for another task force that focuses on the secondary use of data and a cooperation around that. We are preparing this concept note and hope that it can be discussed in Tallinn. We have in Denmark a wide variety of secondary uses, and we have hoped that in this task force we can concentrate on the secondary use in terms of research and development. There might be other secondary purposes, and of course, if the participants want to bring those forward, we are open to that. But at the moment, we have focused on research purposes. We are also hoping to address issues where cross-national or cross-border activities are relevant and needed. So this is not, I know that there are many infrastructural initiatives going on in each member state, and I think it's very important for this task force to focus on areas where the cross-border cooperation is paramount for success. And thirdly, we hope that this, for instance, can underpin the development of precision medicine and other areas where cross-border development and research purposes can actually heighten the level of healthcare delivery in Europe. Next slide, please. Yes, we have suggested some initiatives. We also hope that these are areas that we can discuss in Tallinn, but we observe a quite diverse infrastructure and legal framework in Europe, and we think that if we need initiatives that can be actually implemented and moving forward, we need to address these legal differences. I can understand from the previous presentations today that there are different ways of addressing this in a more common way, but nonetheless, I can say from a Danish perspective that we have, for instance, a wide variety of uses that do not include consent, And of course, we need to be open to the different legal structures in each member state. So given this outset, we would like to make analysis of barriers and opportunities. We would like to make a healthcare data overview. What kind of resources do each member state have that are relevant for common use and common infrastructure? And we would like to map out the different initiatives that go on in member states at the moment. We know from the area of personalized medicine that there are quite a lot of national initiatives enabling secondary use of data, for instance, for personalized medicine purposes. And we think it's very relevant that we map these out and share the learnings and solutions across member states. Next slide, please. So we suggest that we create a new task force with the interested member states. You could say coalition of the willing or the coalition of the doing, but this is at least the coalition of the interested. We would like to discuss the concept note at the upcoming meeting, and we would, of course, there be interested in revising and specifying the objectives and initiatives for this task force. And fourthly, we would like to form this network, and we suggest, in order to move forward, that we established it in an already existing infrastructure within the different relevant agencies, and this could be, for instance, the eHealth network. This was all from me.
Thank you, Marie. Thank you very much. You can type questions if you have some in the question box. I had one, perhaps. Are you expecting interest from only member states or national agencies, or could it be regions, or could it be other kind of stakeholders?
It could also be other kinds of stakeholders, yes. But I think it's also
companies, including.
Yes, but I think it's also important that we discuss whether this task force is moving forward and obliging the member states to work together, and that would entail that the authorities and the public agencies and the ministries can see themselves in this, or we suggest a broader network that might have a little bit longer, how could you say it, a longer perspective, and might not present as many results on the short term, but have a broader involvement. And I think we need to address these, which way we want to go about it.
Okay, thank you. So we will put on our website as well the information for this action group to prepare the new task force 5, so after the 4th one, and the rest of the material. Thank you very much, Marie. So just to conclude this part of the webinar on the task forces, all the material, presentations and instruction to participate in each task force will be displayed on our website. So you, as attendee, you will receive of the webinar, you will receive a specific email inviting you to look at the information once we have the video and the different documents online. It will take a few hours only, and we will give you all this material and instructions. Just next chapter in this webinar was quickly to remind you about the conference in Tallinn this month on the 16th, 18th of October. As you understood through the presentation of our task force leader, each of these task force will have a session specially dedicated to each topic. We will have 1 hour discussion on each of these topics, so it will allow us to and allow the leaders to present in more detail what has been discussed among the experts, and some of these experts will be part of these panels discussing the different topics, and as an attendee you will have the possibility to ask more direct questions, but also we won't have only 4 sessions on these 4 task force. We have many sessions, as you can see on this slide. We have 3 different tracks with more than 70 high-level speakers. About 750 attendees are expected in Tallinn in 2 weeks. And these attendees are coming from Europe, obviously, but as well from the rest of the world. some speakers and attendees from US, from Australia, from Canada, as Angela said, from a delegation from India, a delegation from China, where Brian and Ian were last week to present in Beijing at an event the work around digital health society and the work around the Estonian Presidency of Europe. So it will be a really, really international event with many tracks. You have the website here. Next, please. And in terms of content, these tracks are where the program is organized around 3 main topics. You have at the top right here on the slide, track number 1 about people, track number 2 about technology, and track number 3 about this enabling environment ecosystem we were talking about today. So different sessions, many sessions, and you have here on this slide some keynote speakers and high-level speakers, some of our task force leaders, well, all of our task force leaders will be presenting. We have as well some commissioners, so Andros and Sip will be represented, and we have a message from his staff, and then Vitenis Andriukaitis from the Commission as well will be there, and the Minister of Health and Labour in Estonia, Evgeny Osinovsky, will present there. Well, we have many stakeholders presenting in Tallinn, so I encourage you to check the program. You have the link here at the bottom left of this slide. You can download a PDF version of the full program to have an extensive view of the program, and you will see that we have always three sessions in parallel, so you have a lot of choice to attend different topics, and we invite you to register on the website you have here on the screen. Next. So I will hand over to Aina, Victor, and Brian to conclude and explain a bit the next step and the approach we have for the digital health society in the next month. Brian, Ian.
I think, Ian, maybe perhaps you'd like to start.
Thank you all. Well, Julian and team at the ECH Alliance, and obviously all the task force leaders and our new friend from Denmark working with the action group. When we started in May with a humble proposal that something like digital health society could perhaps help us in shaping the agenda for both the presidency, EU presidency for Estonia, but also give some guidance for the future. And on that meeting, as Herko mentioned, Eric Gerritsen stood up and said, well, perhaps we should not focus only on planning and discussing, but actually get some concrete ideas on table that then those who are willing and capable of acting upon could do so. Now, what was presented today really has exceeded the expectations that we dared to expect, which means that all 5 groups that have been working, and 4 of them quite extensively in our understanding, have true content to discuss, and this is what I understand now ECH Alliance and the Digital Health Society is intending to do, to get broader feedback for that, but from our side we will continue offering first the conference as a platform to discuss and really get now the support on those very practical suggestions and grow it to the extent that either in the form of memorandum of understanding or letters of intent. Well, we have been innovative and inventive as we have gone so far. So we have still a few weeks to discuss which form these actions will take. As mentioned, there is also the public consultation ongoing on behalf of the Commission in preparing their communication, we are still in the discussion of the Council conclusions. So I believe the results of these task forces and the Digital Health Society will be put on table of those groups. Oh, sorry, I forgot. eHealth Network is preparing their annual work plan, multi-annual work plan. I hope that Digital Health Society will stay alive for quite some months and years, hopefully. We will try to facilitate as a presidency to deliver these messages to different decision-making boards, and I really invite everyone to contribute both to the content of these suggested actions, but also to the process, how to make them become a reality. Once again, thank you everyone for the contribution. Over to you, Brian.
Thank you. Thanks very much. And first of all, I just want to echo Ian's thanks to everyone who's contributed. Given how short a time you were all given and the pressure put on you to deliver, I would just thank you, because you have delivered, and you've delivered on specifics. I like the correlation of the doing. We all need to be willing, but we also need to be doing. So we're grateful to Eric and Herco for reminding us of that. I think we all agree with that. What I would say to you in general, though, is this, that the movement, we should not forget this, there are many people outside of the task forces who have contributed to the consultation, but also been in touch with us directly. And we have all had many, many meetings with interested parties who are determined to see the DHS succeed, continue beyond the end of the Estonian presidency, and just to be aware that we are all working very hard to ensure that this, I think, great idea and movement does not end at the end of this presidency. I think I can say with some confidence that it will continue. The only question is at what level will it continue and what intensity, because that will depend on achieving some funding or support from different people. But I can tell you now for sure that it will continue even if it's not at the same energy level. Secondly, the other thing I'd like to say is that Ian and I, as Julian said, spent part of last week in Beijing at the Digital Health Around the Globe event, and Ian and I had a number of private round tables with members of the government and organizations in China, and we were a little surprised that they knew so much about the Digital Health Society. We kept thinking it was a European idea and discussion, but they have been following us and following the website and are very keen to create an equivalent or same type of organization in China in order to connect their work and their huge task over there with the work that we're already undertaking here in Europe. So as a result of that, we've already had a number of the participants from China apply to come to Tallinn, and we'll continue our discussions there and introduce you to those people if we have time during that event. In addition, our Canadian Alliance is also in deep discussion with many people there on the idea of the Digital Health Society, and indeed particularly our connections in places like Massachusetts and other places in the States are also coming to Tallinn to listen, to learn, and then to keep the connections going. So I think we have started something here. We just have to make sure that we continue it and that we keep reinforcing it. So other than that, I hope to see as many of you as possible in Tallinn, and I think we'll have a very intensive, but I hope enjoyable time there. So we're grateful to all of you. So back over to you, Julian.
Thank you very much both for these conclusions. So thank you very much all of you to attend this webinar. Again, I have sent in the chat box the link for the Tallinn event. We invite you to register to this event, and if you have some questions, please feel free to contact us. But it would be really a good place to discuss within the session, outside the session, to discuss these topics about the Digital Health Society and to network. And I put as well the link for the ECH Dream's website, displaying all the information about Digital Health Society. In a few hours, we will put the presentations, the record version of this webinar, and all the information and instruction to participate and engage with the different task forces that were presented today. Thank you very much again to attend, and we keep in touch very shortly. You have all our contact details on our website. So feel free to contact and engage with us. Thank you very much and have a good day.